All right.
This is chapter 11, right?
Yes. And then magnesium 1.8 to 2.6. You can disregard the significance for now because we're not talking about specific causes here in chapter 11. The causes will be discussed in the chapters where they belong. For instance, we talk about kidney disease. This will be in chapter 68, okay, under acute kidney injury and chronic kidney disease. For liver disease, that would be, I think, chapter 58, okay, so and so on. So we're only discussing chapter 11. So for specifically for sodium, we will look at signs and symptoms only, both hyper and hyponatremia, since the disorders and the treatment for the disorders are specific. Therefore, you will not be tested on it for this exam. Reason is, again, we have to wait until we get to these disorders here, namely, again, kidney disease is chapter 68, so that's next semester. And hypercortisolism, which is Cushing's, is chapter 62, that's in your 5th semester. Understood so far? Because if we treat it now, it will be a long class. Okay, we won't finish. So for our purpose for exam 1, it will only be the signs and symptoms for sodium. Because again, sodium management is specific to the disorder. All right. So like here again, liver is chapter 58, adrenal insufficiency, that's also 62. So it's the opposite of hypercortisolism here. For potassium though, since it wouldn't matter whether or not the potassium is, sorry?
I'm sorry. Can I re-log in because I'm on my, I have the Zoom on my phone. It's so small. Can I just try to go back to the, can you put me back in, please? I'm using the computer now.
I don't see anyone waiting in the lobby.
Oh.
Because it pops up when somebody's trying to enter. Okay, to continue. Potassium, it besides the signs and symptoms which we will discuss and test, we will also discuss management of hypo and hypernatremia in chapter 11, because the management of hypo and hyperkalemia does not change regardless of the cause. The manifestation and especially the interventions are the same. Okay, regardless of what's causing it, the management stays the same. Any question on that so far? So for exam 1, I will only test you on sodium and potassium. Calcium will go later when we get to chapter 22 under cancer, and magnesium later when we get to heart failure, chapter 35. So for exam 1, I'll keep it within sodium and potassium. Questions so far? Very good. Okay. All right, so let's review how our intake and output go. Who is Ethan Joseph?
That's Joanna, but I think she's on her son's computer.
Oh, I see. Okay, just making sure. Thank you, sir. All right, so intake and output. So we have measurable and not measurable intake, and in the same way, we also have measurable and insensible fluid loss, or otherwise called unmeasurable output. So obviously anything wet we drink has water. So if we can measure that, then we record it. However, impossible to record are solid foods and also the water produced by chemical equations or through metabolism. Okay. For output, obviously, if anything wet in the same way comes out of the patient, we measure it. Except, of course, we can't measure how much perspiration or how much we lose in the lungs. These will be accounted for, though, when we talk about fluid restriction, which I'll explain shortly. So urine, emesis, feces. In the case of feces, we're referring to diarrhea here, because we're not, I mean, I personally isn't going to start grabbing a solid turd and squeezing the fluid out of it. Okay, so this obviously, when we say feces for output, as far as liquid, we're referring to diarrhea, okay, liquid stool. And drainage from body cavities, we're talking about wounds. So let's say you have a post-op patient who has a surgical drain, either JP or Hemovac or any other drainage devices. Let's discuss obligatory urine output. So no matter how dehydrated a person is, no matter what stage you are in acute kidney injury, you'll discuss that next semester, there is a certain amount of urine that has to be produced by the kidneys. By the term itself, obligatory, the kidneys are obligated to produce urine output. So when you say anuria, that really doesn't mean zero. Okay, there's really no such thing as a zero urine output. There has to be some minimum. Anuria, in fact, by definition, anuria is defined as a urine output of 0 to 100 ml of urine in 24 hours. So it's not exactly zero. However, if you ask patients who are on dialysis, because it's so small, I mean, you dribble 100 ml is equivalent to 3 cups of those medicine cups we use in skills lab. You remember from spring, if you saw one or if you've seen one in a hospital or a nursing home, those tiny little medicine cups are 30 ml. So you have about 3 of those. Do you count that as urine? I mean, if you were the one peeing that, I mean, it's too small to even talk about, right? So patients tend to say, no, I don't urinate. You call that urination? No, those few dribbles that I made. Insensible fluid loss is around 500 to 1,000. It differs depending on the weather, the season. Obviously, during the summer, we lose more. So this would be more in the 1,000 range in the summer, and probably in the winter, we would put it at 500. But we don't set this. The doctor sets the amount of insensible fluid loss. I'll explain later when we get to fluid restriction. Questions so far? Just interrupt me anytime, okay, if you have any question. Let's go to hormonal regulation and fluid balance. So we've been through busy days, you and I, whether you work as a nurse, LPN, CNA, orderly, or whatever you do. There will be crazy days at work wherein you're amazed at how you survive not getting a meal or drinking water or even going to the bathroom, right? So we don't die, we don't end up in the hospital. That's because we have intact hormonal regulation. So during times of starvation, dehydration, our body adapts. Okay, so we have hormones to make sure the fluid balance in the body is maintained. Okay, but only to a certain extent. Eventually, there will be consequences. Okay, one of them is aldosterone. So this is a compensatory hormone. It is released whenever, these are the triggers, whenever sodium levels drop, or if the extracellular fluid, which is referring to the bloodstream, meaning if the fluid volume in the blood is low blood pressure, for instance, or you're dehydrated, aldosterone is automatically released by the adrenal glands. So this is part of your Renin-Angiotensin-Aldosterone System response. So aldosterone has actions on 2 things, water and sodium. So once aldosterone is released, this will therefore cause sodium and water to be reabsorbed in the kidneys. Thereby, what happens to your urine output when aldosterone is released?
Decrease.
Okay, it will automatically result in oliguria. Oliguria, if we miss that, oliguria is urine output of about less than 400 per day, 400 ml per day. So that is called oliguria. Another hormone released is antidiuretic hormone. Unlike aldosterone though, this hormone only acts on sodium, on water. It does not directly affect sodium levels. So in the same way, this will also act on the kidneys, telling the kidneys to reabsorb water, but only water. There are normal times in the day that we produce this hormone. Usually these are at high levels during the night while we sleep. We have a high level of antidiuretic hormone, which is good because we don't have to get up every couple hours to get up and pee. So this will reabsorb water while we sleep so that we just get it toward the morning. Okay, so your bladder starts to get full toward the morning. So again, this thing only affects water, okay, does not affect sodium, not directly anyway. So that's why it says here, it indirectly regulates electrolyte, because what happens is if you have antidiuretic hormone release and then your body, your kidneys will retain water, what happens to your blood volume?
It increases.
Increase. What happens to the concentration of your bloodstream, of your blood? What happens to the concentration? Is it concentrated or diluted?
Concentrate. Diluted.
We are reabsorbing water because of antidiuretic hormone release. The kidneys reabsorb water. So instead of normally forming urine and eliminating it, the kidneys can't do that because most of the water is reabsorbed as commanded by the antidiuretic hormone. So as it does that, water is added to the blood volume. So what happens to the concentration of the blood? Is it concentrated or diluted?
Diluted.
It is diluted. So therefore, if you dilute your bloodstream, what happens to the electrolyte levels? Specifically sodium, because sodium is normally high extracellularly, meaning you normally have a higher amount of sodium in the bloodstream than in the cell. So what will happen to your sodium levels when you have hemodilution?
Decreases.
It will be falsely low, okay? Even if it's, because you technically didn't lose sodium. Sodium level is the same. However, because you added more water, indirectly it caused a hemodilution hyponatremia. Does that make sense?
Yes.
Okay. All right, let's continue. If we have regulatory hormone regulation balance, these are called regulatory mechanisms. So that's aldosterone and ADH. When we say regulatory, the action really is to increase blood volume, okay, to regulate fluid volume, especially blood volume, or what we call preload. I'll explain that concept later when we get to chapter 33. We also have counter-regulatory hormones. So if we have hormones released during less water, when we have dehydration, or we're losing blood, we're losing fluid, or we're not having enough fluid intake, okay? So aldosterone and ADH is released, okay? So both will be released. This is again in an effort to increase blood volume, to restore blood pressure, to increase preload. However, if we have the opposite, if there's a period of dehydration, fluid deficit, there's also possibly a condition wherein we are in fluid overload, correct? Yes, can that happen?
Yes.
All right, so let's say a nurse is not watching the patient. The patient messed with the IV pump. Instead of running the IV at, let's say, 50 mLs per hour, the patient messed with the pump and then ended up running it at 1,000 mLs per hour. And the patient happened to have a problem with either the kidneys or the heart. So can they handle that much fluid at one time? Yes or no? Meaning
No.
the patient has either,
No, Professor.
right? So no, because your heart and your kidneys are necessary for fluid balance. Now, that would put the patient in fluid overload, correct?
Yes.
Okay, so we also have hormones for that. So when you have a condition of fluid overload, so specifically in the heart, when you have increased blood volume, what happens to the amount of blood entering the heart, specifically the ventricles? Is it normal, high, or low?
Hi.
High.
Elevated.
You put more blood than usual inside the ventricles. Will that stretch the ventricles?
Yes.
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 So that stretching is sensed by the receptors found inside the ventricles. Okay, this will release these peptides right here. These are hormones secreted by the ventricular cells, particularly if it comes from the ventricles. It's called the B type or brain natriuretic peptide. If it's coming from the atria, meaning the atria are the ones that are dilated or stretched, it will be ANP. Either way, whether it's ANP, BNP, these two hormones serve two purposes. So the trigger for the release is in response to, unlike aldosterone and antidiuretic hormone, wherein the response here is low fluid in the extracellular compartment. This one is in response to what? Increased blood volume and blood pressure. So if that happens and the heart tissues are stretched, it will cause an automatic release of both ANP and BNP. So what do these two hormones do? They have effects opposite of aldosterone. So if aldosterone causes sodium and water retention, if the BNP does the opposite, what do you have as a result? So let's review. Aldosterone causes fluid retention, correct? And therefore, what happens to your urine output when you have aldosterone release?
Decreases.
Decreases, correct. Now, if we have a BNP release, which is now opposite that, what happens to your urine output?
Increases.
Will increase. Therefore, the effect of BNP is diuresis, and not mentioned here is it actually vasodilation as well, but that will be found in chapter 33. Okay, so we'll talk about BNP again. For now, we have BNP is causing effects opposite of aldosterone, which is, again, instead of retaining water and causing decreased urine output, it will be the exact opposite. Urine output will be increased. So the patient, instead of becoming oliguric, the patient will now diurese. Question so far? Alrighty, so let's do the two, the emergency compensatory mechanism. So we have two. We talked about aldosterone and antidiuretic hormone. Let's talk about the Renin-Angiotensin pathway. So the trigger here, I'll just explain it using the figure, okay? I won't do the paragraph. You read the paragraph. So I'll explain this figure. So the triggers for your RAS system, so this is Renin-Angiotensin-Aldosterone System. Okay, so RAAS. Okay, so there's two parts here. Here's the renin-angiotensin, and the AS is here. Okay, aldosterone system. Okay, so what causes it to be stimulated? So these are the triggers. You either have low blood pressure, low blood volume, low oxygen, low sodium. So can these occur in a patient with heart failure? Yes or no? Because if you're in
Yes.
heart failure, what happens to cardiac output?
Plummets.
Decreases.
But it decreases.
Okay, decreases. Um, so if cardiac output drops, what happens to blood pressure also?
Drop.
Drops. What happens to oxygen? Because blood carries oxygen. So if you have low blood pressure, low blood volume, so they are the carriers of oxygen. So what happens to blood oxygen in the body?
Drops.
Also drops. So it doesn't have to be all. One of these is enough to trigger the RAS system. So what happens? So let's follow the arrows. Here, any of these triggers will cause the secretion of renin. Now, what does renin do? Renin causes then the release of angiotensin 1, which meets renin-angiotensin. There's a angiotensin converting enzyme, which will be released from the lungs and which will turn this into angiotensin 2. Angiotensin 2 is now the vasoconstrictor. So vasoconstriction here, what happens to the resistance? You narrow the diameter of the vessels, similar to, let's say, you're drinking Slurpee out of a coffee stirrer. What happens to the pressure? If you're trying to sip Slurpee using a coffee stirrer, which is what's happening, you are constricting the arteries and veins, increasing vascular resistance. What happens to the blood pressure?
Goes up.
Increases.
Will increase. So imagine again, try sipping a Slurpee, okay, using a straw. See what happens if you can sip it in. So it requires a lot of pressure, right, to suck that original, great American favorite Slurpee through a tiny little straw. At the same time, the ADH system, which is now your aldosterone, is released from your adrenal glands. And we know this causes reabsorption of water and sodium, increasing blood volume, also increasing blood pressure. So you have two ways here to increase blood pressure. One is to increase vascular resistance. We call this afterload. And then we also increase blood volume, which is preload. So both of these will increase blood pressure. Question. And this happens automatically. You don't need to wait. It takes less than a second. The moment the kidneys sense any of these triggers, it will automatically get the whole thing started. So this will only take 1 or 2 seconds to get going. So that's why if you notice, if you're, let's say, scared, okay, so you're in an emergency, okay, you wake up one morning late. Okay, you're supposed to have clinical at 7 a.m. and it's already 9. The moment you wake up, how do you feel? Knowing that you've missed clinical, now you have to make it up.
Palpitations, panic.
Okay, so renin-angiotensin as well as the sympathetic nervous system is stimulated. That's why what happens to your heart rate?
Goes up.
Right, but remember that the higher your heart rate, the lesser the time for ventricular filling. So although initially, yes, blood pressure will increase, but if this is sustained, what happens to cardiac output? It actually drops.
Decreases.
All right, and then add there your vasoconstriction. So do you feel a cold sweat running down from your head down to your legs when you're in that situation?
Yeah.
Right? Yeah, you throw a cold sweat because that's the vasoconstriction. So there's all of a sudden no blood flow getting to your skin, activating your sweat glands, causing a really cold sweat. All right. So these are the manifestations you see. So did it take several hours for that to occur? Less than a second, right? The moment you woke up and then you thought, oh my God, what time is it? And then you missed a quiz or something, right? And then that reaction occurs. So it's so fast. Next. So this is the whole explanation. I'll let you read that. So here's a clinical application. They tell you an example of, let's say, how this affects a patient with heart failure. So why we use ACE inhibitors instead of allowing the compensatory mechanism to continue. Because although it will help a patient who is dehydrated, however, the same regulatory mechanism or compensatory response might be disastrous in a patient with another condition. All right, so please read it. We'll discuss this more under chapter 35, but it's good to read it now. But for exam 1, we're only looking at fluid and electrolytes. Okay, so let's look at the 2 problems. It's very simple. We only have 2 problems. Either you don't have enough fluid or you have too much. Common causes, they're self-explanatory. So dehydration, you're losing fluid through various means. In fluid overload, you're not losing enough because we normally excrete. If you look at the fluid balance earlier, how much urine output are we supposed to make every day? About how many mLs daily? The table earlier said 1500 ml, right? So if we're supposed to make 1500 mLs of urine every day, if our kidneys fail, can they make 1500 mLs of urine?
No.
No.
No. In heart failure, since they can't pump enough blood to maintain cardiac output, will there be enough blood reaching the kidneys?
No.
No. So as a result, can the kidneys make the 1500 that they're supposed to?
No, they can't.
No. I forgot the fluid replacement. So obviously somebody here, the example I gave earlier, the patient messed with the IV pump, so they got too much fluid at one time. Here's another example. Long-term corticosteroid therapy, steroids cause water retention. And if you use this over time, then that will lead to fluid overload and you look very bloated, weight gain, and actually, anyway, that's chapter 62. We'll discuss that another semester. SIADH, so this is syndrome of inappropriate antidiuretic hormone. So you have extremely high antidiuretic hormone levels. So what will happen to your blood volume?
Increase.
All right, so you're absorbing an enormous amount of fluid here, leading to oliguria. So this is another fluid overload. This you learn in your 5th semester under psych. I'll leave it for that. Water intoxication is when you're being treated for a disorder that requires you to drink a lot of water to replace it. You may end up overdoing the water intake, leading to water intoxication. We'll discuss water intoxication also under chapter 62 under diabetes insipidus. All right, let's look at dehydration first. So whether we're dehydrated or overhydrated or in fluid overload, we assess the same indicators of fluid balance, meaning when you walk into this patient's room, you can assess the same items to determine, to use as a basis whether or not the patient is in fluid deficit or in fluid overload. Now, this concept will apply to any condition, meaning if we're discussing future chapters involving these conditions right here, diabetes insipidus again is in chapter 62. What else? Diuretic therapy is under several actually, but number 1 would be under heart failure. Burns, chapter 26. Hemorrhage, this is discussed several chapters, but mainly in chapter 30 under, no, not 30, 40 under hematologic disorders. Or in 68, 35, 62. Okay, so any of these conditions resulting in fluid and electrolyte disorders or imbalances, you will use and apply the same exact concepts, meaning whatever you learn in chapter 11 applies in these conditions. Okay, so it's the same concept, the same idea. So therefore, assessment and interventions will be very similar because they involve a fluid volume deficit condition or a fluid overload condition. They're just different causes, but the same exact problem. Let's start with dehydration. So starting on this page, whatever you see are the indicators of fluid balance. Number one is weight. It says clearly here, 1 liter of water lost or gained is translated to 1 kilogram. Meaning if you gain 1 kilogram or you lose 1 kilogram of weight, that's equivalent to losing 1 liter of water. And at the same time, if you lose or gain 1 pound, that's equivalent to 500 milliliters of fluid gained or lost. Other indicators are, besides your weight, the others are, let's go to blood pressure. What happens to blood pressure when you are dehydrated?
Decreases.
All right, what about if you're in fluid overload?
Increase.
Okay. And remember hypotension, there is such a thing called postural hypotension. So there will be some dizziness or even syncope, right? When changing positions from lying to sitting or from sitting to standing. Did I say that right? No, lying down to standing or from sitting to standing. Okay, so you get what I mean. So that's an indication right there of fluid deficit. Neck veins. What happens to your neck veins when you're in fluid volume deficit?
It's flattened.
They're sunken.
Okay, they're flat. Okay, what about if you are in fluid overload?
Distended.
So here's flat when you're in dehydration. So here, not only your neck veins, but also your hand veins, okay? They appear flat. It's the same thing whether it's neck or the hand veins. Respiratory changes. What happens to your respiratory rate when you are in fluid overload?
Increases.
What about if you're in deficit? Is there a difference? Actually, no. In both cases, you'll have an increased respiratory rate for two different reasons though. One, dehydration causes increased respiratory rate because your blood pressure is low. So cardiac output is low. So therefore, to compensate, respiratory rate increases because now there is decreased oxygen delivery because of your low blood pressure. In the case of fluid overload though, you have shortness of breath or increased respiratory rate because now you have too much. Okay, so there are now fluid in your lungs causing the increased respiratory rate. Does that make sense? Okay, so same symptoms but presenting from totally different rationale or causes. Skin, it's easy to see dehydration. What will your skin look like? Dry, right? And when you pick it, when you pinch it, what will happen? On a dehydrated skin, it will form a tent, and I'm sure you learned that in fundamentals. Of course, when you have a skin in fluid overload, what will it look like? Especially in the periphery, like in the legs, for instance, or in the pelvis.
Edema.
All right, there will be fluid accumulation there. So there will be edema, okay, because of increased hydrostatic pressure. Okay, let's move on. Neurologic changes. So these things I'm talking about, these are the indicators, okay? So Doesn't matter whether in fluid overload or fluid deficit, you assess the same things. The findings, of course, will be different, but you're basically assessing the same exact um, um, parts of your or functions of your body. Neurologic changes here, both will have some form of changes, okay, whether you're dehydrated or you're in fluid overload. However, in fluid overload, you tend to have cerebral edema, so you may have seizures or brain irritability in the case of fluid overload. In dehydration, on the other hand, the brain cells are also dehydrated. So same way you will have, either way you'll have neurologic changes. However, it's more of increased intracranial pressure leading to the possibility of seizures in the case of fluid overload. Kidney changes. So this one's easy. If you're in fluid deficit, what happens to your kidney function and urine output? So in dehydration, what happens? Let's begin with the amount of urine. What happens?
It decreases.
Decreases.
Go into oliguria, and therefore, if you have less urine coming out, what will be the concentration of that urine?
Pretty high.
Very concentrated.
Okay, right, very good. So you'll have a high specific gravity. What will it taste like?
Sweet? Doesn't it depend?
I don't know. I've never tasted urine, but you tell me.
Salty.
Meant as a joke. Okay, I mean we don't taste urine. All right, what about in fluid overload? What happens to your urine output?
Increase.
It will increase, and therefore, if you have more urine output, what will happen to your specific gravity or the concentration of that urine?
Be less concentrated.
Decrease.
Decrease.
All right, so please review the specific gravity normal range, okay? I believe it's 1.001 to 1.030. Okay. Okay, labs now. So we're done with the physical assessment or physical indicators of fluid status. Let's go now to what will our blood work look like. So we draw blood from a dehydrated patient. Where is it? Okay, they didn't put a table. Too bad. All right, so let's go with laboratory. So we draw blood. Let's look at a dehydrated patient first. So we draw blood from it. So what will that blood look like in a dehydrated patient? What will be the osmolarity of the serum? High or low?
High.
High. So does it look concentrated or does it look dehydrated?
Concentrated.
Concentrated. So look at what the lab findings will show. So it contains more cells compared to water. So what will happen to your hemoglobin and hematocrit? Hematocrit is the percentage of the distribution of red blood cells per 100 ml of blood. So what will it be? Is it high or low?
High.
High.
Very high. So it shows you here elevated. So by contrast, if this is hemodiluted, okay, so if you're in fluid overload, what will happen to your hemoglobin and hematocrit?
Low.
It will be low in fluid overload. Okay, and serum osmolarity, as you already told me that it's elevated, so it will be the opposite when we get to fluid overload. It'll be low. Same thing for your protein and BUN creatinine. Okay, so BUN and creatinine will be what in dehydration? since your kidneys aren't making urine, or at least not making enough urine, and the only way you excrete BU and creatinine is through the urine. So what will happen to these levels?
Will be high.
Will be elevated as well. So BU and creatinine will be high. As far as the electrolytes, it will really depend on what type of dehydration happen, because we can have isotonic, hypotonic, or hypertonic dehydration. However, if we're just looking at a concentrated blood sample, though, the tendency is the electrolytes will also be increased. Okay, but again, it will depend on how did the patient lose the fluid, because we can have fluid loss only, or a total fluid loss, which includes electrolytes. Or in the case of, let's say, you're bleeding, okay, hemorrhage, so you will lose all of it. Okay, so it really depends on how did you lose the blood volume or the fluid volume. So we're done with the labs. So I won't go to the manifestations of fluid overload. We kind of discussed both already. Let's go now to interventions. So your patient doesn't have enough fluid volume. What are your interventions? Thank you, Miss Alexa.
Do you want me to read the whole paragraph, Professor?
No, just tell me. So how do you correct it? The patient is dehydrated. So what do we give?
Fluids. Normal saline.
Very
IV.
good. So either by mouth or IV, whichever is the best case. If the patient, let's say, is severely dehydrated, then it won't cut it if we give them oral. So we have to give them IV fluids, especially if the blood pressure is unstable. So that is chart 11-3. So follow this chart. So these are your interventions. In the case of evaluating, let's say, we have to know whether or not we're giving enough, right? So how do we know that the patient's fluid replacement is already enough? Or if we are giving too much? Do we assess things other than what we already assessed earlier, from beginning from the weight, the vital signs, the heart rate, the urine output, the skin? Are we assessing different things?
Yes.
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 So different, this is everything new other than what we've been talking about earlier? Are we assessing something else?
No.
No, we're assessing the same thing. So we're looking at the patient's
Same thing.
brain, yeah, blood pressure, heart rate, respiratory rate, lung sounds, urine output, skin turgor, everything, same thing. Okay, pulse quality will add there. You know, how strong is the pulse? Okay, so that the same thing. So we're evaluating whether or not our fluid replacement is enough or too much, because you could go either way. As far as to the cause leading to the dehydration or fluid deficit, of course, we will also correct that. So the additional treatment here will depend. So I can't really say, you know, give antiemetics. Obviously, the patient's vomiting or the patient's having massive diarrhea, you give antidiarrheals, or a patient has an infection causing the fluid loss. Okay, so let's say we're talking about sepsis, which is chapter 37 in your 5th semester. Really depends on what led to it. So on top of the symptomatic treatment, meaning the IV or PO fluid replacement here, are all symptomatic. You still have to treat the cause that led to the dehydration at the same time. A few things to consider. Okay, here. Read this for me, Miss Tiffany.
The two most important areas to monitor during rehydration are pulse rate and quality and urine output.
Okay, because these are the easier things to monitor. We don't have to get the patient out of bed to weigh them, although that would be the most accurate, but at least we do it, once a day. We weigh them once a day. However, if your kidneys are getting enough blood flow, therefore they're able to make enough urine. So are the kidneys near or far from your core, as far as from the heart is concerned? Is it close to the heart or farther?
Far?
Distal.
Right, so if you have enough cardiac output to reach and supply blood and oxygen to the kidneys, then you're okay, right? So you're not only covering central perfusion, but also peripheral perfusion. Table 11-4. So this is how you choose your fluids. All right, it's all about what are you trying to accomplish. So let's say it's all about osmosis. Before I go to the whiteboard, let's look at which solutions are what type. So we have here 2 isotonic solutions, saline and actually 3. So we have D5W, D5 water, and LR. This is a very rare, this is not common, so you can forget about D5¼ saline because you'll seldom see that. So the most commonly used are saline, D5 water, and LR. LR is right here. So the basis here for the tonicity of your solution, IV solution, is based always on 0.9% saline. If this fluid if the concentration is isotonic, meaning it's compatible the same concentration as your plasma, any fluid therefore that is less concentrated, less than 0.9% in concentration, is hypotonic. And likewise, any solution that has a greater concentration than 0.9% saline are all hypertonic. So let's look at which are hypotonic and which are hypertonic. So on this chart table, you only have one hypotonic solution. It's only half normal saline. The rest, especially if you put 5% dextrose or more, meaning you're adding sugar molecules to the solution. Here, 5%, 5%, 5%, 5%, or worse, 10%. That's even more concentrated. Okay, so any solution, it could even include normal saline. Look at normal saline here. You added 5% dextrose to it. It's no longer isotonic because this is now having more solutes in it. So you increase the concentration of the fluid by adding dextrose. So you added sugar into it, making it hypertonic. Are you with me so far? So which are your isotonic again? Isos, we have 3. They are?
Lactated ringers.
D5W and saline.
D5W.
So those are our 3 isotonics, and we have 1 hypotonic, which is half normal, 0.45% saline. And the rest are hypertonic. Anything with dextrose in it, except D5 water, of course. The reason this is isotonic is it just looks hypertonic in the bag. Because really, if you put dextrose and water together in a bag, it looks hypertonic. But once you infuse this thing, they separate when they hit the bloodstream, meaning the solution is only hypertonic in the IV bag, but once this is infused, the dextrose and the water separate. Does that make sense?
So
Meaning-
dextrose, I'm sorry.
Go ahead.
Dextrose, it adds tonicity, you're saying.
Right, because they are big molecules. Okay, so any solution you add more solutes in it, it becomes more concentrated, correct?
Yeah.
Yeah, so that's the basic concept. Again, except D5 water, because these, again, it looks hypertonic inside that bag, but once infused, these two separate. They're not together anymore. Once they hit the bloodstream, dextrose goes one way, water goes the other way. All right, so how is this used? Okay, so let's do a whiteboard. All right, you see the whiteboard?
Yeah.
Yes.
So here we have your cells. And this is the capillary, or this is the bloodstream here. This is your blood vessel. So everything is based on osmosis, which is passive movement of water. What is osmosis again? Movement of water from
Higher to lower.
I
I said it backwards.
From low to high.
Yeah.
okay.
Yep.
Opposite, right? Okay, so think of it as a tug of war. So whichever compartment has the higher amount of solutes has a higher osmotic pressure. Therefore, it will pull more water toward it. So let's say we give this patient an isotonic first. Saline, LR, or D5W. As it infuses, where will water movement be? So since it's isotonic, meaning between the cell and the bloodstream, they have the same concentration. So where will fluid movement be?
It stays the same. It's no.
All right, there is no movement. So isotonic stays where you put it. So you put it in the bloodstream, it will stay in the bloodstream. So for what purpose is isotonic solutions used therefore? What condition? I'm sorry?
Dehydration.
Okay, so in the case of dehydration though, this is only the initial. Okay, so dehydration, this is only the initial treatment. Because what is your priority in any emergency? It's airway, breathing, circulation, correct? So in the case of life-threatening emergencies, circulation is your priority. So if the patient's blood pressure is really low, we have to give isotonic. We need to increase that blood pressure to keep the patient alive until we can correct the other problem. Are we with me so far?
Yes.
Yes.
Let's change this now to a hypertonic solution. Hyper. According to osmosis, where will fluid movement go? So these are just,
Outside of the cell. Right?
again, use osmosis as your basis. According to osmosis, if you have a higher osmotic pressure in the bloodstream because you give a solution, where will fluid movement be?
Low to high.
Okay.
Inside the cell?
So which one is lower here, the cell or the bloodstream?
Bloodstream.
Which one is lower in concentration?
Oh, the cell.
No.
Bloodstream is high.
All right, make up your mind. Which one is higher here? You just put a hypertonic solution in the bloodstream.
The bloodstream is higher. It has hypertonic.
Yes, bloodstream is higher, cell is lower.
Or where will movement be?
The
From
cells.
where?
In the cells, towards the cells.
Into
So
the
you are,
blood.
right. Not only the cell, but if you have fluid here in the interstitial space, that will also be move toward the bloodstream. Okay, so if you have either extra fluid in the cell or extra fluid in the interstitial space, that will all move toward the bloodstream because it's a hypertonic solution that you're infusing. Last example. So now let's do
So, Professor, hypertonic goes towards the bloodstream and hypotonic goes towards the cells, right?
Okay, so let's finish this. Now we have hypotonic solution. So which one has a higher concentration, the blood or the cells?
The cells.
Cells.
So hypotonic solution, now the fluid movement is the opposite. So you have now water coming out of the blood and entering the cells. Make sense? So how you decide really depends on what are you trying to achieve? What is the patient's problem? And that's how doctors decide which fluid to use. So throughout a patient's admission, will there be a situation wherein there will only be one type of fluid used the whole time? Meaning they're admitted with normal saline, they stay with normal saline the whole time until they are discharged. Will the tonicity of the compartments remain the same?
No.
No, it constantly changes. So the doctor has to evaluate it daily or even more often. Let's say you call the doctor and the patient's already in fluid overload. So do you stay with the same type of fluid?
No.
No.
No, okay. So you get my point about how to use the fluids. Yeah?
Mhm.
Okay. All right, so let's go back to your textbook. Don't worry, you will get a break sometime. All right, we'll finish dehydration and then we'll continue. We'll have a break and then we'll continue with interventions for fluid overload. The rest of these here, because the patient has low blood pressure, so the rest are supportive treatment. So we're done with the drug therapy. We gave drug treatment for whatever was causing the dehydration in the first place. In the meantime, also, until we achieve our goals of normal blood pressure, the patient remains dehydrated or hypotensive, then you prevent injury, prevent falls, because remember they have dizziness and orthostatic hypotension, and watch, of course, for the fluid and the electrolyte imbalances, which we will talk about next. And it's time for a break. Then we'll go with fluid overload management at 10 p.m. See you shortly.
Okay.
Professor, have you started? Because I don't hear you.
Oh, sorry, I've been talking the whole time. All right.
Sorry about that.
Instead of giving fluids like we did in dehydration, what do we do for a patient in fluid overload? Do we give fluids?
No.
Diuretics.
Okay, instead of giving fluids, we may have to restrict fluids. That's correct. We give diuretics to push them, to push some of the extra fluid out. although we still have to monitor the electrolytes, which may be affected by the diuretic therapy. So here's a critical rescue. So our concern here is pulmonary edema, which is a sign of heart failure. So when you have left ventricular failure, it may cause flash pulmonary edema. It's just a lot of fluid at one time will cause potentially fluid overload, resulting in pulmonary edema. And these are your signs and symptoms. You'll see obviously neck vein distension, crackles in the lungs, although the peripheral edema here will take time to form. So the more immediate or acute symptoms will be neck vein distension and the crackles in the lung. It usually takes about 4 liters of fluid retention before you see peripheral edema. So this doesn't really occur right away. You mentioned drug therapy. So here are the diuretics. We have several options. Conivaptan or tolvaptan is only given for severe hyponatremia. Okay, and then this is specific though with SIADH. Okay, no other condition receives vaptans except SIADH. But again, this will be in another semester, another chapter. So we will skip that part. So we will stick with general diuretic therapy. Nutrition, of course, if our patient already has fluid overload, we typically don't need to give them any more salt, unless it is, again, this is an exception here, okay? But we'll discuss that separately because this is an exception to the rule, okay? But generally, if our patient is on fluid overload, we put them on salt restriction along with the fluid restriction. Again, we weigh the patient to determine fluid lost or gained constantly. And that's about it. So it's pretty simple. So in dehydration, we gave fluids. In fluid overload, instead of giving fluids, we restrict fluids, and then we give diuretics to push the water out. With regards to fluid restriction, the amount is dependent on the urine output recorded during the last 24 hours. Meaning, let's say if the urine output yesterday was only 400 ml, so we give 400 ml today plus around 600. Okay, so the 600 here is accounting for the insensible fluid loss. Remember that? The fluid loss that we lose through perspiration and breathing or talking. You remember that part? Yes, no?
Yes.
Okay, so remember, we're not only losing fluid through the urine, so you have to account for the insensible fluid loss, which is assumed around 600, give or take again, depending on the season and the temperature of the room. And that ends fluid deficit and fluid overload. Any question before I proceed with electrolyte imbalances?
Nope.
All right, so let's do sodium and potassium only. So start with sodium. How you remember this is there's always a pattern. Each electrolyte, of course, stimulates or excites any cell. However, some cells are more sensitive to sodium compared to others. One example are the neurons in the brain. So your brain cells are especially reactive to sodium, meaning sodium imbalances affect brain cells more than other cells. Of course, here, as you can see, muscle contraction can also be affected along with cardiac contraction, but most especially also nerve impulse transmission. And it just how happens that sodium will affect neurological function more than any other electrolyte. If you go to the imbalances and the manifestations, look at hyponatremia. Most of your symptoms involve neurologic changes because low sodium in the blood results in swelling of the brain cells. So here you could potentially have cerebral edema from hyponatremia. And once you have cerebral edema, that will of course increase your intracranial pressure, causing possibly seizures or any other neurologic impairment, including coma. We'll skip the causes again because the causes are specific to the chapter. So we'll skip that. We'll just stick with the signs and symptoms. Cerebral changes. See here, you have cerebral edema and increased ICP. So watch them for seizures and or worse, they might go into coma. So we have to correct the hyponatremia right away. Normal levels are 135 to 145, or in this textbook, it's 136 to 145. That can be accomplished with, let's say, giving normal saline, hypertonic saline. Again, I forgot, let's not do the interventions because, again, it's specific to the cause of the hyponatremia. So let's just stick with these signs and symptoms. There will be neuromuscular changes as well. Weakness is the usual manifestation, especially in the arms or in the legs. GI changes. So the sodium, remember, the sodium is low in the blood. That means in comparison ratio, if it's higher, if it's lower in the bloodstream, what is the ratio intracellularly? If you have low sodium levels in the blood, that means what is the sodium level intracellularly?
High.
Okay, considerably higher compared to the extracellular levels. So you'll see the opposite here. Low sodium, higher, low sodium in the blood, higher in the cell. So look at your intestinal function now. There is increased motility in the GI tract, causing nausea, diarrhea, and cramping. So you'll have increased stool because you have a more hyperactive bowel sounds or peristaltic activity. Now, when it comes to cardiovascular changes, it really depends because you can have hyponatremia in hypovolemia. You can also have hyponatremia in hypervolemia. So we can skip this one because, again, this is specific to the cause. Let me just briefly explain. So if the cause is, let's say, total fluid loss, meaning both, not isotonic, okay, both total fluid and electrolytes. In that case, you have hyponatremia in a dehydrated patient. However, you can also have the same in a patient with fluid overload. In this instance, it's because of the hemodilution here, because you have too much fluid, thereby causing dilutional hyponatremia. So there's really no distinction, okay, with the cardiovascular manifestation because it depends on what was the cause. So for the exam, we'll stick with GI symptoms, the neuromuscular and cerebral changes. Any question?
Nope.
All right, let's go straight to, we'll skip the interventions. Again, they're specific to the cause. Let's go to manifestations of hypernatremia this time. So this is hypernatremia. What are the presentations? So in hyponatremia, we saw cerebral edema and increased ICP. Here in hypernatremia, so you have higher sodium levels in the blood. What will happen to the brain cells? Will there be also swollen or shrunken? Hello.
Professor, what was the question again?
Okay, so if we had cerebral edema in hyponatremia because of the imbalance, what will be the shape or condition of your brain cells here when you have hypernatremia?
Wouldn't they be swollen?
We had them swollen in hyponatremia
It's shrink.
Be shrunken.
and now shrunken or disheveled, right? So the brain cells are also kind of dehydrated. So it always causes deficiency in the volume because of osmosis. Okay, so water will be drawn into the bloodstream from hypernatremia, so shrinking your brain cells. So the patient's manifestations will be lethargy, stupor, and comatose, meaning do you have enough stimulation here of the brain if you're lethargic?
No.
No, because you have less sodium inside the cell. So less excitation, less stimulation, which is the opposite in hyponatremia. In hyponatremia, you're low of sodium in the blood, but you are higher in the cell. So therefore, there was more stimulation, okay, resulting in the seizures. Skeletal muscle changes, some difference here. There will still be some weakness, however, just like in hyponatremia. However, there will now be twitching. Okay, still weak, but then they become more irritable. So you observe for some muscle twitching in muscle groups. Again, we'll skip the cardiovascular changes because this is exactly what happened also in hyponatremia. So you can have hypernatremia in both conditions, depending again on the cause, especially with pituitary disorders seen in chapter 62. Interventions we'll skip for the same reason. We will discuss treatment based on the disorder causing the hypo or hypernatremia. Let's proceed with potassium. So there's not a cell not affected by potassium. You'll see on the manifestations that they are systemic. Okay, so almost every cell is affected by potassium imbalances. It has a very narrow range, 3.5 to 5. We do not store potassium. The only source of potassium is fluid or food intake. So you saw the imbalances in your post-op patient because they are NPO, so they had hypokalemia as a frequent problem. A bit of trivia here, which is very useful. Since in hypokalemia, the management here, of course, is to replace potassium. Before you replace potassium orally or intravenously, you have to check kidney function because of this fact right here. 80% of your body's potassium is removed through the kidneys. The remaining 20% you excrete through your GI tract and through your skin, through sweating. Therefore, since the kidneys eliminate most of it, if the kidneys are not working, can you eliminate potassium?
No.
What will happen if you started with hypokalemia and then you gave this patient either oral or IV potassium and then there's no kidney function? What will happen? Will you still be in hypokalemia?
Hyperkalemia?
End up with hyper, and we
Because
know
you can't excrete.
right. So either hypo or hyperkalemia, both are equal. The patient will go into cardiac arrest with either problem. So again, before giving any potassium, always check kidney function, okay? For both the patient's sake and your license sake. Regardless of the cause, we'll skip the causes. Let's go to signs and symptoms and then treatment. Let's go with, okay. So since potassium excites all cells, good thing though, that most of the foods we eat pretty much will contain potassium. Look at this, highest though, and we'll look at a chart later. There will be a chart enumerating the foods that are low and high in potassium, mostly in dried. Okay, most fruits have them, but especially if you dry the fruit. So the fruit releases the potassium from inside the cells of the fruit and retain it in the dried form. Most meats have potassium, so pretty much anything you eat most likely contains potassium. Respiratory changes. So they will excite cells, especially muscles. And remember that the diaphragm is a muscle. So if it's, are we doing low? Yeah, hypokalemia. So therefore, if your potassium is low, it will weaken muscles. In fact, whether your potassium is high or low, you'll see muscle weakness in both imbalances. Particularly in respiratory changes from related to hypokalemia, there is weakness. So you may see respiratory depression here. Another is musculoskeletal, as I already mentioned, they have weakness. Okay, so every post-op patient, if you see weakness, they refuse to get out of bed, saying they're so tired, consider the potassium levels. Check it, and it could be the one causing it, preventing them from ambulating. Or if they feel miserable, look at the intestinal changes. So if you have hypokalemia, look at the GI symptoms. Decreased peristalsis, so the patient is bloated, they have nausea, vomiting, constipation, a bloated or distension. Again, common in most post-op patients, right? So it could be a electrolyte imbalance, not just that's causing the decreased peristalsis on top of the effects of your anesthesia and pain medications. Cardiovascular changes, I won't test you on the ECG changes yet. I'll do that later. So these ones here, that's in chapter 34, 2 semesters from now. Neurologic changes, lethargy, going to confusion and coma. So that is for, and then hypotension. So those are your manifestations for hypokalemia. Let's go to management now. Best practice is, of course, you're deficient in potassium. What do you think is the treatment? You don't have enough. So what will we do?
Potassium.
Just like in dehydration, you lacked water. So what did you do?
You had one.
IV infusion.
IV and insulin.
You gave fluid, right? So this time you're low in potassium. So what do you get? Potassium replacement. So we have different options, either PO or IV. PO can be a pill, or you could also increase the diet, okay, the potassium in the diet. But for moderate hypokalemia, which is now around 3 or less, that's already moderate. So we now give them IV. The importance of IV is you're limited to the infusion rate. The safe infusion rate, 5 to 10 milliequivalents of potassium per hour. You should not give more than that concentration every hour or that amount. Although somewhere here in a drug alert, it tells you that still the same 5 to 10 milliequivalents per hour in IV. However, the rate is never to exceed 20. That means you can extend it to 20 MAQs per hour, but personally or any nurse I know, we've never given potassium at a rate of 20 milliequivalents per hour. It's just too risky. So in my career, I've never given it higher than 10 MAQs per hour. Besides, the patient will complain. Okay, this right here, potassium is a very irritating solution. Okay, so never give it IM or sub-Q. Plus, even if you give it IV, it still irritate the veins and cause phlebitis. So most patients will shout, yell at you to stop the infusion or at least slow it down because it can burn the veins. It's very caustic, okay, very irritating. Even though we have potassium in our body, but when it comes in a IV infusion, it is very irritating. So the you can stop at the infusion. You don't have to do the signs and symptoms because we already did that in the paragraph. So we give oral potassium, IV. Again, your IV access, of course, should be working properly. Otherwise, it will exacerbate the burning, especially if it's infiltrated. Okay, so consider infiltration if the patient doesn't stop crying or yelling. Okay, it does burn pretty bad. For some of you who've seen it in the hospital infusion, you know what I mean. Or if you've received potassium yourself intravenously. So here, stop it if you suspect infiltration. Again, you don't have to worry about that. The patient tells you, cusses at you because of the pain. Because we are limited to a rate of 10 milliequivalents of IV potassium per hour, is it easy or hard to treat hypokalemia?
Hard.
Extremely hard. So if you're at a level of less than 3, let's say 2.6, 2.7, that's already severe, it will take at least 24 hours or even 48 hours to correct that. Okay, so in the meanwhile, in the meantime, you just have to keep the patient safe. So that's why we have here, if possible, put the patient on telemetry, monitor their heart function, because it's impossible to correct it in a short amount of time. So you're limited by the maximum infusion, which is 10 milliequivalents per hour. So in the meantime, if the patient goes into severe dysrhythmias, at least you have them on a monitor. You can see the dysrhythmias unfolding and you can call rapid response to treat the patient. Okay. Until then, you just continue with your replacement. Be patient. You can also increase potassium in the diet and avoid any other drugs that may cause more potassium loss. Okay, or let's say they're having diarrhea, so stop that. Try to stop the cause of the loss. Okay. Any question? And here, of course, you guys know you shouldn't push potassium, right? I hope you do.
Yep.
Okay.
I do not.
Oh, okay. For those who
Oh, they
said
told us in skill lab.
not give that, you'll kill the patient. Okay, we do that in death row. In let's say you're executing an inmate. This is the we give them, make them comfortable first. We give them we sedate the inmate.
Yeah, isn't that a painful death, the potassium?
Not if you do it correctly. So you, like I said, I was saying you sedate the patient, you give them muscle paralyzers, so they're out. Okay, they're unconscious, they're unaware of the pain because you paralyze them. Plus they're sedated, and then you give a lethal dose of potassium chloride IV, and that's it. They go into severe arrhythmia, and then that's it. Bye bye. Let's go to hypernatremia, hyperkalemia. So this one is the opposite. So you have high potassium level, greater than 5. Regardless of the cause, manifestations are the following. So they mimic the manifestations of hypokalemia. They're almost similar, except the EKG effects. Okay, they're opposite. So you'll have tall peak T waves here, but what am I saying? I'm not testing that yet. So let's do neuromuscular changes. It's almost, again, identical. So you see weakness here, of the skeletal and respiratory muscles. Although the respiratory muscles don't really get affected until your potassium level is really high, though. But you'll see it happening just the same. Intestinal changes, complete opposite. So you had decreased motility there, causing distension, nausea, vomiting, right? And constipation. Here you have increased motility. Now you have diarrhea and cramping. Interventions. We have several options to drop potassium. We can either shift the potassium, meaning take it out of the bloodstream, put it into the cells temporarily. We can give drugs that will promote excretion of potassium. And that's pretty much it. So let's start with shifting, because the shifting will be the fastest way to do it. There's a new drug here, Hypernatremia. Honestly, I've never seen that in clinical. We still use K-Exolate in clinical. K-Exolate is sodium polystyrene sulfonate, SPS. But this is in your book, so I guess it'll be on the NCLEX. But honestly, I've never given this drug. I really don't know what it does, but sounds like it's the same as SPS, the same as K-Exolate. So it still binds with potassium in the GI tract. However, this one decreases absorption, unlike K-Exolate, which still binds with potassium in the GI tract, but then it excretes it, because K-Exolate is a laxative, meaning it promotes GI motility. It promotes bowel movement, and it takes potassium with it. However, in the case of K-Exolate, it takes 2 up to 4 hours to work. So if your potassium level is really high, you can't depend on K-Exolate alone. It won't drop it until 2 to 4 hours later. So therefore, in the meanwhile, you need to do something else in order to lower the potassium level. And please read this on your own. So same as hypokalemia, we still put the patient on a cardiac monitor because just as it was hard to increase potassium, it can also be hard to eliminate it. However, there's an option to shift it. So we can use IV fluids with insulin right here and glucose. It has to be both. Do not give insulin only or glucose only. It has to be both. So the purpose here, the drug really that will drop potassium by putting it inside the cell temporarily is insulin. If you give IV insulin, it will take potassium into the cell with it. However, because the insulin will drop your blood sugar, you have to give glucose with it. So as insulin is infused, it brings glucose and potassium inside the cell, taking it out of the bloodstream. However, like I said, this is only a temporary effect. So this will buy you maybe 2 hours, just the duration of the insulin given IV. So after the insulin wears off, the potassium will go back outside into the bloodstream again. At which time the K-Exolate or this pentasa right here would have worked at that point. Okay, meaning it will buy you time until your potassium excreting diuretics or your potassium excreting resins, which is K-Exolate, works. Again, the K-Exolate works 2 hours later. So in the meantime, you need to drop the potassium levels fast. And you can do that with insulin and dextrose. Or other textbooks say calcium gluconate will do the same, but it's not mentioned in your textbook. So we don't do that on the test because it's not found here. Diuretics will also help. This one will work 30 minutes to an hour later. However, what else will you lose though, besides potassium?
Sodium?
Calcium.
It will also cause fluid loss, and then to some extent, yes, sodium will also be lost. Okay, with especially with loop diuretics. In the event that it's really severe and you need it fast, they may have to do dialysis. They'll do emergency dialysis, put in a temporary dialysis catheter, and dialyze the patient. Okay, that would be the fastest way. So again, to summarize, there are a few options here for responding to hyperkalemia. First, put the patient on a monitor for safety. And then the first thing you would give, if you have all of these orders, this would be the first thing you give. Go with the IV insulin with dextrose first, because this will work the fastest. So in a few minutes, maybe 15, 20 minutes, it already starts because that's the onset of insulin. So your potassium starts dropping. However, remember that this is temporary. It will not be a permanent fix. After giving that, then you give your diuretics and or your potassium excreting resin, the Kayexalate or sodium polystyrene sulfonate, or this guy right here, this new drug Patiromer. They do not work right away, but at least you have them on board. So by the time insulin wears off, the potassium excreting diuretic or the resin is already working. Any question?
No.
All right, that's the end of electrolytes. We'll stop right here. Oh no, last one, 11-6. This is your list of foods that are high in potassium. So this is under hyperkalemia. That means when they say you should avoid, that means these foods right here are very high in potassium. And when it says you may eat, that means these foods right here are low in potassium and are therefore okay to eat. And that's final, that's it. Questions?
No.
No.